Good morning, Chairman, ladies and gentlemen. Thank you very much for the invitation to argue against the case for focal therapy. I have no relevant disclosures. So we've heard some very balanced, very positive views about focal therapy just now from Raphael, and I admit that I have been well known for being pretty negative about the role of focal therapy over the past 10 or 12 years, perhaps sometimes a bit harsh about the role of focal therapy. And what I want to do this morning is not dismiss focal therapy, not put my head in the sand and pretend it's going to go away. What I want to do is explore a theme of uncertainty about focal therapy. And I think we'll accept that in life, of course, we all expect some uncertainty. This week here, everyone in Barcelona was eagerly awaiting the Champions League draw on Friday to see with what certainty they might finally regain the Champions League. And I think there is some certainty in this if we're trying to consider positive influencers, risk stratification that might say a good outcome is quite likely in this situation. Whereas in Melbourne this morning, as we speak, the Formula One Grand Prix is coming to an end, and this is a much less certain environment. It's difficult to make predictions about whether Lewis Hamilton's going to win again because there's more uncertainty in that type of environment. And then consider the ultimate uncertainty that we've been observing unfold over the past couple of years, where we have an environment of complete uncertainty, complete chaos. And I think in life, if we can avoid this type of self-inflicted uncertainty and chaos, then that's probably a good thing. And in medicine, we as clinicians have always accepted some degree of uncertainty. I think that's true. But in more recent years, especially as we evolve towards a more precision oncology approach where we define the diagnosis better, we profile the patient at an individual, often molecular level before we plan treatments, I think this is a much more precise environment we've emerged into. So what then of focal therapy? And despite the advances we've heard in imaging and in ablation technologies in this field, I think there are three areas of uncertainty we should reflect on. First of all, as we all well know this morning, MRI is the fundamental enabler of defining the type of patient who now needs a biopsy or certainly is going to be subjected to focal therapy. And we've heard that there are a lot of limitations, even in good centres, inter-observer variability, etc. And in our centre, we have an interest in improving the limitations of MRI in planning for focal therapy using machine learning approaches. We've just published this experience where we take men coming for radical prostatectomy who have a research protocol MRI and a PET scan, because we have a lot of interest in PET tracing in our centre. Then they have a radical prostatectomy and an ex vivo MRI. And what we're trying to do is take very detailed information, not simplistic things like PIRADs, which are subjective to inter-observer variability, but take voxel level data, mathematical data from the MR and mathematical data from the PET scans, and together put these into machine learning algorithms. As you see here, this is voxel-based MRI versus SUV. And let me tell you, ladies and gentlemen, this is too complex for humans, of course, which is why machine learning algorithms may be a solution here that at least mean we take sophisticated things like MRI with all the voxels, etc., and PET imaging data and see can we improve limitations in imaging in selecting patients for focal therapy. A second area of uncertainty, in my view, is biopsy, because, as we've heard, most of these lesions are best characterized when we use a multiparametric MRI and often a transperineal prostate biopsy. But oftentimes, the technology we then use to deliver the focal therapy is not using a multiparametric MRI and a transperineal biopsy. It's very often that we've beautifully described it, as you see in these pictures from experts showing the index lesion, but then we're trying to see can we identify that same lesion and ablate that same lesion using much more primitive approaches in some circumstances. And the third area of uncertainty, or perhaps opportunity, is in the types of technologies that we've been using to roll out focal therapy. And we've heard about some of these this morning from Christian and Raphael. Have we yet found the best focal technology, or can we agree on the best focal technology? I don't think we're quite there yet, which is an area of encouraging research. There's a lot of interest, of course, in radio-ligand therapy using lutetium PSMA, for example, in men with very advanced prostate cancer. And we have a lot of interest in this in our centre. We've just published an overview of where we think this might go, because now it's in men with very advanced disease. But I think we'll see lutetium-based therapy move forward to less advanced disease and perhaps even into early disease, perhaps in the neoadjuvant setting. Here's an example of one of our patients in our prospective study published in Lancet Oncology a few months ago, who has very advanced prostate cancer. But watch what happens to the prostate in this gentleman who has widespread metastases and receives lutetium-based PSMA. You can see pre-therapy, he's got an extremely avid lesion within the prostate. We treat it with very targeted lutetium-based therapy, I would say almost focal therapy, and we get a complete response within the prostate, both on PET imaging and very favorably with his PSA. So I think there may be a role for lutetium PSMA and other targeted therapies, intravenous radiotherapy essentially, as a focal technology. So I think it's fair to say that I've softened my historic opposition to focal therapy, and myself and Daria Tilke have recently written about this. I think if we as clinicians and with our patients accept MRI as a key tool for diagnosing and staging patients, then we have to accept a reasonable amount of uncertainty. And that's okay, provided we have informed decision-making and we're all aware of that uncertainty. And I'll finish then again by reflecting on the sort of spectrum of uncertainty we have in life that I've referred to earlier, and consider that with respect to focal therapy. I think if we want maximum certainty, then we should only offer focal therapy within clinical trials. And this remains the strong recommendation of the EAU guidelines. I think if we accept a bit less certainty, we should offer focal therapy within a registry, not as robust as a clinical trial, but at least we have some good parameters. And I think what we should not do is have the chaos that I think is ongoing around the world, where focal therapy is being offered and delivered in unrestricted environments against guidelines. I thank you very much for the opportunity.